Blood Component Replacement by Lieutenant Cadet. During surgery, 3 million units of blood products will come in contact with anesthesia providers each year. Understanding regarding the principles of blood product administration. Currently, the blood supply in the the rate of viral infections associated with blood transfusion in the United States has greatly increased over the last 20 years. This is mainly in part due to universal testing for blood. The rate of transfusion related to hepatitis C is currently the lowest of all the hepatitises. However, 85% of people infected with hepatitis to chronic disease and 20 of those with chronic disease will develop cirrhosis. Anywhere from 1 to 5% of those with chronic disease will develop hepatocellular carcinoma. Hepatitis B has the greatest risk of transfusion-related infection. This is likely due to the fact that at the time of donation, donors may have contracted the virus but detectable on surface antigens. 35% of people exposed to hepatitis B will develop the disease. The majority of those who develop the disease will have spontaneous resolution, but 9% and 1% will develop hepatocellular carcinoma. The likelihood of contracting hepatitis A from a blood transfusion is there is a history of exposure. Since the 1980s, the rate of HIV transmission due to transfer greatly decreased. It was the discovery of the transfusion-transmitted HIV that has greatly changed many blood bank practices and helped decrease the overall transfusion rates. In the United States, all donated blood products are screened for HIV and HIV-1 and HIV-2 viruses. Currently, the rate of transmission is 1 in 1.7 million. The human T-cell lymphotropic virus is in the same family as HIV and is associated with leukemia and lymphoma. All donors in the United States are currently tested for human T-cell lymphotropic antibodies. As such, the risk for transmission is very rare in the United States. Transfusion-related cytomegalovirus, or CMV, is usually not a serious condition and tends to be self-limiting in the healthy patient. However, immunocompromised patients may experience severe and even fatal infections if exposed to CMV-positive blood. In order to reduce the risk of transmission, immunocompromised patients should receive leukoreduced blood from CMV-negative donors. It is possible for the West Nile virus to be transmitted through blood transfusion. Fortunately, there is a very short window from the time the virus is contracted until symptoms are present. This helps decrease the likelihood of West Nile positive patients from donating blood, as well as donor screening in areas where the virus is prevalent. The majority of those affected with West Nile virus will be asymptomatic or have only mild symptoms. The transfusion of malaria via blood transfusion is common in countries where the disease is an epidemic, but very rare in the United States. Chagas disease associated with the protozoa is much more common in South and Central America, where the disease is much more common. Non-viral transfusion-related infections have a higher rate of morbidity and mortality than viral infections. According to Barash et al., bacterial contamination occurs at a much higher frequency than infection and is associated with substantial mortality. According to Morgan and McHale, it is the second leading cause of transfusion-associated mortality. Unfortunately, transfusion-related bacterial infections occur more common than viral infections. There is an increased incidence of bacterial sepsis with platelets due to the fact that they are stored at room temperature and numerous organisms, including strains of Staphylococcus and Klebsiella, can grow platelets. The risk of sepsis further decreases with apheresis platelets because they are obtained from a single donor, reducing the risk of contamination. Only a limited number of bacteria is capable of growing on red blood cells. Patients who receive contaminated blood may have a variety of symptoms and a varying severity of these symptoms. Some will quickly experience fever, chills, tachycardia, dyspnea, shock, and possibly DIC. The source of contamination of blood products can be as simple as skin flora during collection. In order to prevent contamination, storage of blood products is necessary. All blood banks in the United States now test their non-apheresis platelets for bacteremia, as well as many institutions also test their apheresis units. Immune reactions occur when the recipient has developed antibodies to the donor's blood products. In rare instances, the donor cells mount an immune response against the recipient. Immune reactions occur when the recipient has or develops antibodies to the donor's blood products. In rare instances, the donor cells mount an immune response against the recipient. Hemolytic reactions involve the destruction of the transfused cells by the recipient. Incompatible units and transfusions, and is usually due to an ABO incompatibility, usually from the mislabeling of blood products. Acute hemolytic reactions take place in the intravascular and sometimes in the extravascular space. The complex is formed by the antigen antibodies activated factor VII. Factor VII helps produce bradykinin by its action on the kinin system. Bradykinin increases capillary permeability and causes arterial dilation, contributing to hypotension. The release of histamine and serotonin from mast cells causes bronchospasm. Up to 50% of patients will develop DIC. Acute hemolytic reactions occur with as little as 10 to 15 milliliter reactions is fatal. The signs and symptoms of acute hemolytic reactions in the awake patient might subsequent transfusions. Symptoms of a delayed transfusion reaction are typically mild and require only supportive care. Diagnosis of a delayed transfusion reaction, Coombs test. Likely due to sensitization to donor white cells. The use of leukoreduced blood products can help to limit these reactions. Febrile reactions are from white cells or platelet sensitivity. This reaction can occur in 1 to 3% of patients who have received a previous transfusion. Symptoms include an increase in temperature of more than 1 degree Celsius within 1 hour of transfusion and will return to normal within 48 hours. Accompanying symptoms may include chills, headache, respiratory distress, nausea, symptoms similar to a cold. Treatment is geared towards radiated prior to transfusion in the immunocompromised patient. Thrombocytopenia following transfusion is caused by the development of platelet antibodies that can cause destruction of the recipient's platelets within 5 to 10 days. Treatment of post-transfusion purpura includes the administration of IG and plasmapheresis. According to Morgan and McHale, recent studies suggest that perioperative transfusions may increase the risk of post-operative bacterial infection, cancer reoccurrence, and mortality, all of which emphasize the need to avoid unnecessary administration of blood products. A massive transfusion is considered to be any transfusion process with 1 to 2 times the recipient's blood volume, roughly equivalent to 10 to 20 units in adults. Risks associated with massive transfusion include coagulopathies associated with the dilution of the recipient's own clotting factors. During massive transfusion, it may be necessary to monitor the patient's coagulation studies, including but not limited to PTT, PT, INR, viscoelastic analysis, and thromboelastography. Citrate is used as a preservative in blood products. Citrate binds to calcium and during a massive transfusion will bind to the recipient's own calcium, causing hypocalcemia. Hypocalcemia is less likely to occur in healthy patients when the transfusion rate is less than 1 unit per 5 minutes. Because hypocalcemia can cause cardiac depression, it is important to monitor the patient's calcium level during massive transfusion. Citrate is primarily metabolized in the liver and temperature. It is important to maintain temperature during transfusion as the ventricular arrhythmias occur at temperatures close to 30 degrees Celsius. Acid-base disturbances during massive transfusion are related to ultratransfusion, especially if the rate of transfusion exceeds 100 milliliters a minute. At rates this high, hyperkalemia and intraoperative arrest have been observed. Ideally, initial blood loss should be replaced with crystalloid or colloid solutions to eliminate unnecessary risks associated with blood transfusion. The anesthesia provider, along with members of the surgical team, will need to make a decision as to when the risk of anemia associated with the blood loss supersedes the risk associated with blood transfusion. There is no magic number at which blood products should be replaced. The decision needs to be made based on each individual patient's clinical picture. At hemoglobin 75 milliliters per kilogram for males and 65 milliliters per kilogram for females, allowable blood loss is calculated by subtracting the estimated blood volume times the starting hematocrit from the estimated blood volume times the minimal hematocrit. This number will all decrease the transfusion threshold as well. FFP should be given to treat T's 1.5 times normal. FFP can be used to quickly reverse warfarin therapy and to treat heparin resistance. It is also to be used to correct specific factor deficiencies that are not available alone, such as factor V. The indication for replacement of platelets includes maintenance of prophylactically for patients with thrombocytopenia prior to surgery or other invasive procedures. Cryoprecipitate should be administered when there is microvascular bleeding in the presence of disproportionate decrease in oxygen, such as DIC, when bleeding due to uremia is not responsive to ddAVP. Prophylactically for patients when hemophilia A and von Willebrand's disease prior to surgery, and for patients with a factor 13 deficiency. After administration of blood products, lab values should reflect the replace of vascular fluid. Normally, the administration of 1 milliliter per kilogram infusion strategy is used. The hemoglobin will increase by roughly 3 grams per deciliter, and the hematocrit will increase by approximately 10%. FFP will increase levels of all clotting factors by 2 to 3%. A pooled unit of platelets will increase the platelet count by 5 to 10,000, while an apheresis unit of platelets will increase the platelet count by approximately 30 to 60,000. A unit of cryoprecipitate can increase a patient's fibrinogen level. Prior to the administration of blood products, each donor unit must be tested for compatibility with the recipient. There are 3 tests that a unit of blood product will undergo prior to administration. The first is ABO testing to determine which antigens are present on the red blood cells. This is important because most people develop antibodies towards the non-present antigens. Type A blood has A antigen bodies. Type AB blood has A and B antigens and no antibodies. Type O blood has no antigens and both A and B antibodies. Next, the donor blood is tested for D antigens. Blood with D antigens is considered to be Rh positive. People with Rh negative blood will have D. A blood transfusion reaction will not occur. The cross-match mimics a transfusion by mixing the donor and recipient blood products, incubating for 10 to 15 minutes at 37 degrees Celsius, and checking for compatibility. The cross-match will confirm ABO and Rh compatibility, as well as detect if there are antibodies present. Determining ABO and Rh status alone is sufficient to predict 99.8% chance of compatibility between donor and recipients. The addition of antibody testing only further increases the probability of compatibility. However, patients with a history of antibody reactions, patients who have a history of transfusion, pregnancies, or antibodies should always have a cross-match prior to the administration of blood products. The type and screen only test the recipes present. The blood bank will identify